Welcome everybody. It is Tuesday, the first Tuesday of the month at 5 p.m. Central Time. So it's time for DeBakey CV Live AFib. For probably 9 months out of the year, we do the AFib webcast at 5 p.m. on Tuesday. And this is a special webcast. A couple of things I wanted to get out of the way first, though. Well, as you know, we're at Houston Methodist Hospital at Texas Medical Center, deep in the heart of Texas. For those of you who wish me well on my birthday yesterday, I'd like to publicly thank you all. I got tons of very nice notes from colleagues and patients. So thank you for wishing me well on my birthday. Secondly, this is Heart Health Month, so you might see some things about AFib on the internet. This is a special presentation in that I have operated on several surgeons over the years, and surgeons have a unique way of assessing risks and opportunities and risk benefit, because that's what we do as surgeons every day. So I thought it would be helpful for our community to hear from another surgeon who suffered from AFib and how he went through his journey and decided what to do, the pros and cons, and give you, the audience, an opportunity to ask Dr. Evans questions. So this is an unusual opportunity. Of course, after the live event, this will be posted right away and you'll still be able to see it. But for the next 50 minutes, you'll be able to ask Dr. Evans questions if you like. As you know, the way we do this, there are two ways. One is right on your phone. It's 37607. You can see it on the screen now. And then you type in DeBakey, D-E-B-A-K-E-Y, and send us a question, and we'll try to get to every question that we get this hour. It can be any question about AFib. It doesn't matter. And there are no bad questions or poor questions. Also, if you're on your computer, you can join by the web. You go to pollev.com, P-O-L-L-E-V.com. Again, enter DeBakey and then respond to the activity. So there are two ways that you can ask us questions. Please do not wait till the end of the session. Get your questions in early, and we will take questions as we move along through the hour. So I ask you, please get your questions in early so we may get to your questions before the end of the hour. Dr. Seth Evans is a otolaryngologist, aka ear, nose, and throat surgeon, ear, nose, and throat physician, or ENT surgeon. These are surgeons that deal with disorders of the head and neck. Seth practices here in Texas. He's in Austin, a suburb of Austin, Texas. He's a private practitioner, and he's gone through this exercise that many of you go through about what to do when you have AFib. How aggressive should you be? Which way should you go? What treatment is best for you? So I thought it would be very illustrative for Dr. Evans to share with you his story. He also has put some of this out there on social media, and we'll show that on the screen. He's given us permission to show a couple of things on the screen here. If when the producers have it ready, it'll show the, you got it? There it is. You guys are very proficient. So is that right, Seth? DrSethEvans.com, Wolf and Seth, or evans.seth@gmail.com. So
that is correct.
If your question is not answered, or you think of a question, Dr. Evans has been kind enough to allow you to discuss this with him, or he can answer you on social media. So we'll put that up there a couple times through the hour. So that's what we're going to do today here at DeBakey for AFib. Again, Seth, thanks so much for joining us, offering to help other fellow patients that suffer from AFib. And maybe the best thing to do is start from the beginning and tell us how this happened. If you want to say your age, you may, but you don't have to. But you're a relatively young surgeon, and just sort of go through the details with us and give us some insight. Welcome to the program.
Sure. Well, thank you for having me. I consumed a lot of these webinars, so it's nice to give something back now. So I'm 45 years old. I was 44 just over a year ago, which is, I believe, when I first started having episodes of AFib. So we're talking like January of 2023. And the way I was first kind of clued into it is I have a sleep monitor on my bed. And it sort of records your heart rate, your respiratory rate, all that kind of thing. And I started noticing, my heart rate while I was asleep was like 80 or 90, whereas normally it was running in the 40s. And I was sort of like, what is this? This is weird. And then it kind of went away for a few weeks. So I just sort of thought, I don't know what that was, but that was strange. But then in March, it started happening again. And it was pretty much every night, March through April. I would get these spikes in my heart rate in the middle of the night, usually when I was asleep. And it was starting to kind of linger into the morning. And I took my pulse, and it felt irregular. And I was, I know enough through the years of medical training that I thought right away, I think this is AFib. So I ended up getting an appointment with a cardiologist here in Austin, and saw him in late April. And we did the Holter monitor, where they kind of monitor your heart rate for 48 hours. And that picked up an episode. And at that point, I was officially diagnosed with having AFib. So the cardiologist recommended that I go see an electrophysiologist here in Austin. And I kind of dragged my feet on it. I was trying to do, diet changes and lifestyle changes, and, identifying what was maybe triggering this. And I did kind of find out if I ate low calorie and low carb, like I was trying to lose weight, I would get episodes of AFib. But if I ate a bunch of junk food, I actually wouldn't get episodes. So I ended up, of course, gaining about 15 pounds over the course of the summer. But I wasn't getting that many episodes of AFib for a couple of months. Now, once we got to like July, August, kind of started to come back again. And I kind of found through this whole thing, the AFib was always very unpredictable. The minute I kind of felt like I had it figured out, it would change, and whatever I was doing wouldn't work anymore. So I ended up finally seeing an electrophysiologist here in Austin in late August. And he recommended strongly to do a catheter ablation. He said that I was young, I was having, paroxysmal AFib, which means the AFib episodes would come and go. So that was an ideal candidate to do it. And he told me it was a 90% success rate. So I was like, great, this sounds awesome. So I went ahead and scheduled it, about a month after that. And then, I started researching catheter ablation. I read a couple of books on AFib. I was watching videos on YouTube, reading about this online. And basically every source said catheter ablation is the way to go, it's particularly for younger patients like me. So I was pretty much set on it. So one day I was on YouTube, I was probably watching something about catheter ablation, and suddenly the next YouTube suggestion shows up, and it's a video called Why Catheter Ablations Fail. And Dr. Wolf is the one who made that video. So I started watching that one. And after about 5 minutes, I was like, holy, something we don't want to say on the Methodist webinar. So I was very surprised and listened to this whole thing. And pretty quickly, I was like, wow, this Wolf Minimaze surgery, this makes a lot of sense, with how this works anatomically, and listening to how people have failed catheter ablation and why, it really got me thinking, maybe this is not the right thing for me to do. So, I started watching more of Dr. Wolf's webinars. I started reading into the data on especially the longer term outcomes of catheter ablation versus the Minimaze surgery. And I basically requested to have a virtual consult with Dr. Wolf. So sometime in September, I had my virtual consult with Dr. Wolf and, asked a number of questions of him and said that, I think I said at the end of our call, how do I sign up? And so, we ended up, getting the insurance cleared. I believe I actually got a date, which not until next summer, but I think you either had a cancellation or somehow you were able to get me in for the surgery earlier. And I ended up having the Wolf Minimaze surgery November 13th of last year. So I'm now coming up on 3 months since having had the surgery. And I mean, it's been a great experience. Since the surgery, I have been in sinus rhythm other than about 6 hours. 2 weeks after the surgery, I had a little bit of atrial flutter, which is like a normal thing during the healing process. Other than that, I've been in sinus rhythm the whole time. And I really do feel like I'm cured. I guess we can't ever know what the future holds, but, I feel, from what I know about this surgery and how things have gone so far, I feel really good about my, hopefully the rest of my life not having to worry about this problem anymore.
Well, as you know, there are two parts to this. One is the symptoms can be rather significant. For some people, they're incapacitating. Two, they're worried about when their next event is going to occur, so they are concerned about getting on a cruise ship or going on a long trip. And then thirdly, but maybe not number three, is they're worried about a stroke. Now your CHAD Vascular score was probably very low, so the chances of a stroke are much less. You're young, normal body habitus, so I think you probably had a CHAD Vasc of 0 or 1.
Yeah, I was 0, so I was never on blood thinners.
Yeah.
But I mean,
that was another reason we were able to move you up. We didn't have to worry about, and you're almost local. Well, Austin's about 3.5 hour drive, but that's considered almost local for some people. Now, I just saw a patient today from Hutchinson, Kansas. He's having surgery tomorrow, Minimaze. He came here from Kansas. He's 45. He's already had 3 ablations. Yeah. And he is not a happy camper. Now he's in a constant arrhythmia. So, of course, I see the failures, but there are a lot of patients who've had 3 ablations even as a young patient and still have a lot of issues.
Sure.
So I don't know. Sometimes I think it's they say, well, you do better if you catch it earlier on, but it may be a bias, it's called a length time bias. I don't know if you've ever heard of that, but let's say you have a cancer and it's going to metastasize in 5 years. If someone diagnoses that cancer when you're in your 4th year, it metastasizes a year later, okay? So you say, well, gosh, that didn't work out very well. But you could, if you would have seen him 5 years before and it didn't metastasize until the 5th year, you'd say, oh, well, we did well because we kept it from metastasizing for 4 years. But you really don't know that. It could have been that it was going to metastasize in 5 years no matter what you did. But there's a length time bias if you catch it early. And sometimes I wonder if that happens with AFib. Whereas the AFib is going to get worse in 5 years. So if you do a catheter ablation 5 years early, you say, well, we caught it early and you didn't have recurrence for 5 years. Or you could have caught it on the 4th year and it came back in 1 year. But in fact, it's all the same thing. It's just a matter of when you intervene and the way you look at it. That's called a length time bias. And sometimes I wonder if that happens in AFib.
Yeah, I mean, it could. It's interesting looking at long-term outcomes. It seems like the EP doctors, they like to quote 1 year outcomes.
That's true.
That's what my doctor did, and they're pretty good. But once you get to 5 year outcomes, it starts to get less good.
Yeah.
But
That's
for paroxysmal, it's 60%, remission at 5 years with one catheter ablation,
yeah.
which it's not terrible, but it's not that great,
Right.
especially when you're comparing it to 95%.
That's right. Now I had lunch with a patient between Christmas and New Year's this year, and he wanted to have lunch with me because he was off all medications, including blood thinners. He had continuous AFib. His heart function was poor when I initially saw him, with an EF of 15%, normal being about 60. And he had had previous coronary bypass. We did the Minimaze, and his heart function returned to normal, and he's off all medications. Now here's the kicker. He's a colonel, retired colonel in the Air Force. He's 85 years old. I operated on him when he was 65. So he's 20 years out. And he's still
Wow.
AFib free, and now he's got normal heart function. They were thinking about putting him on the heart transplant list because his ejection fraction was so low. So a point to remember is that if the heart function is depressed by AFib, if the heart returns to normal function, then the ejection fraction can return to normal as well. I mean, it doesn't happen in a day, it happens over several months to a year, but it's totally reversible, which is a good thing to remember. Let's see. Can I ask a few questions? And I have some more questions for you, Seth. Let me just
Sure.
take a few questions. And again, for those of you who are sending in your questions, thank you. And maybe, Mr. Producer, we ought to put the sign up one more time about the ways to contact us. Oh, you got it up there at the bottom of the screen. So you can see, you can join by text, 37607, and then put in DeBakey, or if you're on the internet, on your computer, go to pollev.com, enter DeBakey, and ask us a question. I'll take it from the top here. If you had AFib for 15 years, can the Minimaze help? Well, absolutely, and I would ask a lot more questions. What seems to be the most important is how long the heart has been out of rhythm continuously. So if the heart's been in and out of rhythm for 14 years and out of rhythm continuously for 1 year, that's not bad at all. And we do people that have been continuous AFib for even 5, 6, 7, 8 years, because it also depends on the size of the left atrium. A good look at the left atrial size can predict the results of different procedures. And in my experience, if the left atrium is less than 6 centimeters, or even say less than 5.5 centimeters, the outcomes are very good. Also, even if the left atrium is larger than 6 centimeters, but the heart's been in rhythm within the last couple of years, at least the last 5 years, then we still get a good outcome. So it's based on how long has the heart been in continuous AFib, not total time, but completely out of rhythm. Has it been more than 5 years? That's a marker. And is the left atrium larger than 5.5 centimeters? I use rule of fives, it's easier to remember. So if one of those is true but the other's false, you still can be a good candidate for the Minimaze. A good example is a patient of mine from over a year ago. He's been out of rhythm for many years, and he's in the medical device business, and he comes into operating rooms, so he knows a lot about this stuff. He wasn't going to do anything, but his left atrium wasn't too bad. It was right about 6 centimeters. He's a year out from Minimaze, off all medicines, in sinus rhythm, feels like he got his life back. Can you talk about the difference between the Minimaze procedure that uses large incisions versus the one that uses small incisions? Well, it depends on what you mean by large or not. Seth had the Minimaze as I originally did it, which on each side are 2 incisions about this big. They're usually about a couple of centimeters. And then a bigger incision on each side, which tends to be between 5 and 7 centimeters. Now, just for the sake of understanding this completely, a little historic note. Initially, when we started doing these, I did do some with only the ports, so only the small incisions, no big incision, the big incision being 5 to 7 centimeters, which is the tips of your 3 fingers are a little bit bigger. And there was no difference. There was no difference in how much discomfort the patient had after the procedure. We even did a couple patients where we made the bigger incision on one side and only the ports on the other. And it turns out they hurt more where we did the ports only. I think that's because with the ports only, the instruments rub against the intercostal spaces when you move up and down. And with the bigger incision, that doesn't happen. So I haven't seen any advantage at all to just only smaller incisions. I've seen some major disadvantages. It's more difficult to get to the areas that you need to address. It's much more difficult if the patient's had previous ablations and their scars, or if their lung is scarred, and it takes much longer time. So in my experience, the larger incisions do not add anything to the time in the hospital or the discomfort. In fact, they have less discomfort. We have an average stay of about 2.5, 3 days. Seth, I don't remember how long you were in the hospital.
I had surgery Monday morning. I was out of the hospital before noon on Wednesday.
Okay.
So about
and that's pretty
8
typical.
hours.
And some of the people that do only the small incisions brag that their patients are only in the hospital for 4 or 5 days. Well, we're already down to usually 2 or 3 days anyway, so I really don't think it makes any difference. If someone is very good through the small incisions and it doesn't take them a long time and they don't have complications, that's fine. What's the risk of short or long-term complications specific to opening and closing the pericardium? I'm quite remote from Houston. What support do I ask for from my local cardiologist/EP versus that received from Dr. Wolf post-procedure? Okay, well, for every heart surgery, the pericardium has to be open, and most commonly people watch this on the YouTube and they say, Dr. Wolf, you didn't show closing the pericardium. And that's true, it's not on that video because we were already at about an hour on that video. But in fact, I do close the pericardium on each side. There have been a few patients, the years down the road, have needed heart surgery for one reason or another, bypass surgery or valve surgery. And it's been no problem to go back in because the pericardium is still intact in the front. These incisions are on the side and then the pericardium's closed. The biggest risk is post-pericardotomy syndrome. What that is inflammation of the heart sac after any intervention, including some EP intervention. So if blood is introduced into the heart sac, you can get it from any different way. We try to decrease that incidence. I think we do successfully by treating it prophylactically. We treat post-pericardotomy syndrome before it starts with steroids right after the procedure, and also colchicine, which is a very old and reliable gout medicine that's been shown to decrease inflammation of the heart sac. So I think the key is don't get any blood inside and close the pericardium and use steroids and anti-inflammatory agents to decrease the chance of post-pericardotomy syndrome. Why do the WOP incisions appear to be smaller than the WM incisions? Okay, WOP is Wolff-Otsuka procedure versus Wolff Minimaze. Dr. Otsuka is one of my trainees. He is in Tokyo, and he does do only ports, no big incision, in a normal-sized patient. And I've been with Toshi in Tokyo, and as you may guess, the Japanese patients are ideal for size. A normal BMI is 19. I did 19 BMI 19-year-old lady today, and it's so much easier to do the procedure, and you can make smaller incisions. But in the United States, generally the BMI is not that small. And in fact, Toshi has told me in the larger BMI patients, larger size patients, height and weight, that he does make a bigger incision. But he does make ports only in the typical Japanese patients. So he's one of my proteges. He does the procedure very well. I visit him there. It's a difference in technique. I don't think it makes any difference in the conclusion. Is it better to have the left atrial appendage removed or clamped? The first 1,000 patients, we didn't have a clip, so I removed it with a stapler. Seth, I used to use the regular surgical staplers, that they're titanium staples, and it worked very well. And I used one that laid the staples down and had a knife on it, so it cut the appendage off. And I used to give the appendages to patients so they could put it on their in their living room at home. But when the clip came along, I started using the clip. This was about 9 years ago. The clip is a little bit faster, it's a little bit easier, and it's a little bit safer. I still open the appendage after I put the clip on and make sure there's no flow through the appendage at all. But either way is fine. My protege Toshi in Tokyo still uses the stapler, but he uses it for a specific reason. And that is, the clip is very expensive in Japan. It's cost prohibitive in Japan, so he staples them. And I would too if the clip was cost prohibitive. It's not in the United States. So I pretty much switched to the clip just because it's a little bit quicker, a little bit easier, and maybe a little bit safer. Have you ever advised a patient to have an ablation instead of Wolf Minimaze? Have you ever advised a patient to stay on rate and rhythm control meds instead? Yes, I have. Every patient is different, and that's why I think a personal consultation is the key. There's so many other little things that come into play. It could be the patient's had previous surgery. It could be the patient's not a good candidate for surgery. It could be that the patient is not having much AFib, and maybe rate or rhythm control is enough. I have some patients that come to see me, and I say, what's your AFib burden? They said, well, I have one episode a year. Well, I'm not sure you need a catheter ablation or surgery for that. In some patients, they don't know, and we put in a link. And then we say, let's be objective about this, and let's see what your AFib burden is. If it's less than 1% or almost nothing, maybe you don't need anything. If it's 5%, 10%, if it's interfering with your lifestyle, then maybe you do. So we can get very objective with it, with the link. Can you tell during the Wolf Minimaze if a patient's AFib has resolved itself? Generally, no. You cannot. You have to wait. But what I do is I test entrance and exit block, and that's what we did in Seth's case. So I have a special instrument I can put right on the surface of the heart, and we can look at the veins, we can see the signals in the veins, and then we place the clamp, fire the clamp, and we check again, those signals are gone. That means we have electrical block. We then also pace those veins, and if pacing the veins doesn't pace the heart, we have a block. So we test for block, and if we have block, we're good. I did a patient yesterday morning. It had 2 ablations, and we tested before we started. There was no block. 2 previous ablations, but it wasn't blocked. After we put the clamp on and then removed it, completely blocked. So we do objective testing during the procedure, but you can't tell for sure if that takes care of it all. Does nerve damage from going to the chest through the ribs heal over time? Generally it does. There are some superficial nerves. Those are the first to go and the last to come back. Seth tell us your personal journey with the surgical part of it.
Yeah, I mean, I never really had more than mild pain. I basically just took Tylenol afterwards. About 2.5 weeks after the surgery, I stopped taking any regular Tylenol. Maybe would take it like once a day. And by about 3 weeks after the surgery, I wasn't taking any pain medicine at all. At this point, I feel pretty much like my usual self. I feel fine. I still, if I sneeze, I get a little bit of pain. And I think it's probably from the nerves being stretched, but it's very mild.
Okay. Now, what I've found is the best predictor of discomfort is body habitus. So in general, but there are exceptions to this too, in general, if the patient's morbidly obese, they tend to have more pain after the procedure. And I think that's because you have to do more manipulation to get to the target. And it's probably the same in your field of work too. It's technically more difficult and maybe a more painful recovery with a much larger patient.
Yeah, I think that's true.
So that's something you don't usually see on Facebook, and I understand that. People don't put their height and weight on there, but that's just something I've noticed. Having said that, there's some patients that have been quite large I've operated on, and they've, like you, they really essentially had no pain. So it's hard to know. The nerves are different in everybody, where they are, superficial nerves. I wear magnifying glasses so I can try to see these nerves and push them out of the way so we don't damage them, but it's not 100%. Seth, we'll get to some more questions here in a minute, but I want to get back to you. Tell us a little bit about what you did for other people on social media and to explain your journey and what options there are for patients.
Yeah. So before I even had the surgery, I think this was back in October, I kind of summarized the research that I had done for myself. And what I was really interested in were the longer term outcomes. So 5 to 10 years after the procedure instead of just 1 year. It took a little bit of legwork to track that down for catheter ablations. Because again, the outcomes aren't so good the longer out you get. What I found was basically, it's only about a 60% success rate with a catheter ablation at 5 years, whereas it's 95% for the Wolf Minimaze for someone in my situation. So a lot of that, outcomes data that I had found and researched, I wrote up a summary of that into a document. There's also some information in there about, the complication risks. I think catheter ablation and Wolf Minimaze are both very safe procedures. But honestly, the risk of complications is actually lower for the Minimaze in a lot of ways. And I think anatomically, the catheter ablation is going inside the heart within the bloodstream. So, I do think you get particles and things floating around potentially from that. They can cause strokes and other problems that we don't get with the Minimaze. So
there were two studies. There were two studies done where they measured transcranial Doppler. So they're to your point, they're looking for particles or gas that's going up the carotid artery into the brain, into the middle cerebral artery. And both studies looked at catheter ablation, and they averaged 2,000 to 4,000 hits or particle something that goes into the brain during a catheter ablation. 2,000 to 4,000. Now, most of the time, this does not result in an overt stroke, but patients were interviewed, and the most common thing was a frontal headache or other minor things. And then there was a study where they looked at MRIs after catheter ablation, and there were changes in a large percent of the MRIs of the brain. Because of that, we thought here at DeBakey it would be good to look at that with the Minimaze, which we did. So with Dr. Lumsden's help and the head of the non-invasive lab, we did transcranial Doppler while the patients were asleep for the Minimaze. And the number of hits was 0. So difference between 2,000 little pieces of crap going into the brain versus 0 with the Minimaze, to your point. Sorry to interrupt you, but I wanted to amplify that point.
Right. Yeah. I mean, I think, when you compare the two options in terms of procedures, I mean, the Minimaze, it has better long-term outcomes, and it has, low and even less complications, I think, than the catheter ablation. So, I mean, I think the only place where maybe a catheter ablation might be preferable is just in terms of pain and suffering afterwards. And again, I mean, it's still pretty mild for the Minimaze for most people. I mean, I think with a catheter ablation, you're probably kind of up and about pretty quickly.
Yeah.
Whereas I was sore for a few weeks after the surgery, but I mean, it was not anything more than kind of mild soreness. This was not where I was laid out in bed and I couldn't do anything. I was up walking around, and
I point out to some patients that the catheter ablation is less invasive on your skin. That's for sure. It's a punctures in the groin. But I think it's more invasive on your heart, because with the Minimaze, it's like drawing a pencil line to interrupt those nerves. Whereas catheter ablation, it's more of a blanketing burn on the inside of the left atrium. So it's more of it's much more invasive on the inside of the heart than the Minimaze.
Mm-hmm. Yeah, absolutely.
Now, where'd you post your information?
So it's on that link that was posted at the beginning of this.
Oh, Mr. Producers, could you put that link back up while Seth is talking? Thank you.
And then it's also in the Facebook group. There's the Wolf Minimaze Facebook group. It's in the files section, but probably the easiest place to find it is at that drsethevans.com link.
What else is in there, Seth?
That I did. There's also, it's just kind of a day-by-day experience of the surgery and my recovery. So I just wrote that up to kind of, shed a little bit of light on the experience and how it goes.
Okay, great. Let's jump into a couple more questions if it's okay with you. Would you briefly discuss the cause and significance of a single 6-second pause with no symptoms detected on the loop recorder I had, the Wolf Minimaze? There are a couple different causes. The most common one is there's a bit of arrhythmia, some extra beats, some supraventricular tachycardia that may last a few seconds, maybe not enough to cause symptoms. And when the heart resets, when it goes out of this abnormal rhythm back into sinus rhythm, it's normal to have what we call a compensatory pause. So the heart just stops for a few seconds and then it beats normally. So a general rule of thumb is, if we see a pause, don't treat the pause, treat the symptoms. So if a patient has a pause but they have no symptoms, they don't get lightheaded, they don't pass out, we don't treat it. If they're having symptoms, that's different. And I've seen patients with up to 10-second pauses that are compensatory. Their heart is resetting itself. It's almost like your heart doing its own cardioversion. And it's normal to have a pause to reset the electricity. So it's probably a short time of rapid heartbeat followed by that resetting, the pause, and then back to normal rhythm. A question: what, if any, effect is there on the heart rate at the upper end when a person is exercising at a high level, as in hiking hard in the mountains? I'm not sure I get the question, but I do know this, that I have a lot of patients that are athletic, cyclists, and so forth, and they tell me at 6 months they're fine at going up to 140, 150 heart rate, and then when they cool off, within 5 minutes their heart rate's back to 50. Now, Seth, your heart rate was low, but I guess that's probably because you were pretty good shape. Tell us what type of exercise you would normally do before this AFib thing started.
You know, I was always kind of I don't really like doing crazy intense exercise, so I would try and do, short amounts of uh, high intensity interval training. So, I did some body weight exercises, push-ups, pull-ups, kettlebell swings, that kind of stuff. I've actually, since about a month ago, I've started doing more weightlifting actually. So I've still kind of eased off. I'm not doing much kind of cardio, running or biking or that kind of thing yet. So, I mean, I was maybe going to try and get in a little bit more into that in a couple more months. My resting heart rate now is usually around 80 during the day, and it's like about 65 when I'm asleep. So,
that's very common. That's a good point, Seth, because it's very common because after this, it's really a partial cardiac denervation. Now, there are lots of autonomic nerves on the heart, on the atrium, on the ventricle, the aorta. They're all over. What we're trying to do is denervate just around the pulmonary veins in the left atrium. And generally, you get a vagolytic response. Vagolytic means the vagus is the nerve that slows the heart down. And you tend to take that out more than the sympathetic, which speeds the heart up. I believe in most patients, you're born with your own pacemaker that's happy to beat at 60 beats a minute your whole life. But you have all these nerves coming in from your hypothalamus, from your spine. We call them the sympathetic and the parasympathetic areas. And they're telling your pacemaker what to do. And I think it's based on the way we evolved. At one time, we had to increase our heart rate very quickly to maybe get away from a lion or tiger. And these nerves gave us a way to very suddenly increase heart rate and escape. And by these nerves also evolved to say, well, if you're lying around, you just ate a big meal, we're going to slow your heart rate. So there are all these interactions that these nerves have from your brain, from your spine, and even on your heart. There's been research to show that there's even almost like a small brain on the heart, and these autonomic nervous input and output are going on your heart. And if those are out of balance, then you go into AFib. When the AFib treats these nerves, it generally, you get more of a vagus effect from it. So you take out the vagus and your heart rate tends to be higher for a while. Now I would expect over time your heart rate's going to come down. But it hasn't yet. But you're not even fully 3 months out yet, are you?
Yeah, it's not quite 3 months.
Yeah.
In fact, I just, I'm taking a medicine called flecainide, and it's sort of an antiarrhythmic. And I lowered the dose of that a couple weeks ago, and it's funny, my resting heart rate dropped by about 10 beats per minute when I'm asleep, away.
I'm glad you mentioned that too, because generally I like to use amiodarone pre and post-op, but you were already on flecainide, and you said it did help you. So I didn't want to change it. We just left you on the flecainide, and you're weaning the flecainide, which is another antiarrhythmic that's commonly used for AFib. I don't use it much though for the Minimaze. Should I have any concerns over future cardiac surgery down the road when the surgeon might be concerned? No, we've not. That's happened, as I mentioned. We've had patients that have needed open heart surgery for one reason or another. It's been no trouble to go back inside the pericardial sac after the Minimaze. I have early Parkinson's. I heard general anesthesia can speed up the progression of Parkinson's. Have you had many patients with Parkinson's? I've had many patients with Parkinson's. Parkinson's is very common, so I can't tell you how many I've had, but it's been a lot. But I'm not an expert on Parkinson's, so it probably would be inappropriate for me to comment on whether or not the anesthetic caused a problem or not. It's not my area of expertise. Dr. Evans, do you have any comment on that?
It's not my area of expertise either.
Okay. How can you detect existing clot in the left atrial appendage? can you still perform the Minimaze? Can you still clamp the LAA? Great question. This comes up a lot. I get patients from around the country who've been told they have a clot in their left atrial appendage. They can't be cardioverted because the clot could break loose, and they can't have any procedure. Generally speaking, it's a false positive. What false positives mean in medicine and surgery is that we see something, but it's really not there. In this case, usually it's an echo, and it's suspected there's a clot in the appendage, but it's not really there. How do we tell if it really is a clot? We do a CT scan. The CT scan is so much more specific and valuable to assess a blood clot in the left atrial appendage, and specifically with the delayed image. If you go to your regular hospital, wherever you are, they probably won't do a CT with the delayed image. We presented this at a radiology conference 15 years ago when I was at the University of Cincinnati. It's called the 60-second solution. If you get a CT scan and do a 60-second delayed image, you'll see the appendage fill. If it doesn't, then there's a clot. But, excuse me, almost all the cases I've seen, they've been false positives. In fact, when we do the CT scan, there's no clot there. So the answer is you got to have a CT scan to see if it really is a clot. Sometimes the appendage folds over on itself like a floppy ear, and it gives you a double image, and it looks like a clot, but it's really not. Why disqualified if you've had mitral valve repair versus aortic repair? Okay, well, the mitral, this is someone who's had previous surgery. Mitral valve repair is right where we work to do the Minimaze. And there's scar there, and there's enough scar that it's very difficult to get around the back of the heart, and I think it's too dangerous. So it would have to be an open maze after a mitral valve repair and not a Minimaze. The aortic repair is the aortic valve. It's in a different spot. It's not where we're working on the left atrium, so it's quite okay to do a Minimaze. It's a relative contraindication, but I've done many patients who've had aortic repair and it's worked out fine. Do you recommend taking amiodarone if you're experiencing AFib and are waiting for a Minimaze? Yes, I do. I think it helps a lot. I did 2 patients last week, continuous AFib. They were cardioverted, didn't work, but they hadn't been on amiodarone. I put them on low-dose amiodarone, and within one patient was 1 month, the other 2 months, they self-converted to sinus rhythm. And when they came to Houston, they were in rhythm, had their Minimaze, stayed in rhythm post-op, and now we'll wean the amiodarone. The amiodarone settles the heart down. It increases the chances that the heart's going to stay in rhythm after the Minimaze. So if patients who have been on antiarrhythmic or who have persistent or long-standing persistent AFib, it's extremely helpful. The key is I don't use large doses, low dose. That's the key. Low dose and give it plenty of time. No loading dose. Have you had any failures? Of course. Does LAA ever tear when clamping? I have not had that. We've had 100% success with left atrial appendage. We've had no operative deaths. Have there been failures? Yes. There have been people that we've done that unfortunately still have AFib. Generally these are patients who've had AFib a long time, or they're patients that have had multiple procedures. But still, what's a failure? I have some patients that have 1 AFib bout a year, and they used to be an AFib 100% of the time. Is that a failure? Not according to the patient. Is there any long-term issue with having your LAA clamped? Yeah, there's a long-term issue with having your left atrial appendage clamped. You're much less likely to have a stroke if you ever have an arrhythmia again. But no downside of having it clamped at all. Back to you, Seth. We're getting close. We got a few more minutes left, but I wanted to give you a few more minutes on any other area you'd like to discuss, or any suggestions to our listening audience.
Yeah, I think the biggest thing I wanted to mention is, if you're looking into the Wolf Minimaze, I mean, I do think you kind of have to be a researcher. You have to be your own independent thinker and decider. And you have to be prepared, I think, to maybe push through some resistance from, your local doctors, and potentially your friends and your family. I think you have to educate yourself about this procedure. And I mean, there's great resources. There's all of these webinars on YouTube. There's the Wolf Minimaze website. There's the Facebook group. So you can definitely educate yourself and learn what this is and, what are the benefits and what are the risks. And once you've done that, you're going to know more about this surgery than probably your local cardiologist and your local electrophysiologist.
Yeah.
And when I spoke to my EP doctor here in Austin, I told him, I'm planning on doing the surgical ablation. I don't want to do the catheter ablation anymore. And I mean, he immediately started talking about how I was going to get my chest cracked open and I was going to get a Cox-Maze procedure. And I was like, no, that's not what I'm doing. And, they will just make assumptions and they're going to go down that road and they're going to tell you it's a bad idea and it's a major surgery and this is way too much. And that's exactly what my doctor told me. And again, I don't think he's a bad guy. He's certainly very experienced with what he does. And I don't think he's a bad person at all. But, I think he did jump to an assumption when I told him what my plans were. So I think you have to be prepared for that. And I mean, you have to be somebody who will take your own health into your own hands. But I think for most people, it's worth it. At the very least, talk to Dr. Wolf, do a virtual visit with him and, see what he thinks. And, for many people, I think this is a really great option and it really does give you a chance to be cured and not just managed long term, which I think most of the other typical treatments that's what they're trying to do.
Well, what you're bringing up is look at all your options. You did talk to the EP. You did talk to me. And I encourage that too. If someone has only talked to me and they haven't talked to the EP, I encourage them to talk to an electrophysiologist. Look at both sides. I think that's the only way you can really weigh your options carefully. I think the only physician we should be concerned about is the one who doesn't want you to get a second opinion.
Sure.
Right?
Yeah.
I mean, that's what you want in a physician. If you say, can I get a second opinion? You want them to say, well, of course, please do. And get back to me and if you have any other questions. Let's see. Good afternoon. I've had the Wolf Minimaze May 2023, mostly normal sinus rhythm, feeling great. I've been having random PVCs. These are premature ventricular contractions, and what the cardia calls supraventricular ectopy. So you're having extra beats. Now the premature ventricular contractions come from the lower chambers, the ventricles, and that's generally not related to your AFib. And some people have both. They have atrial arrhythmias and ventricular arrhythmias. Usually PVCs are not treated unless they're incapacitating. They can be treated with ablation with some success, but generally if you're not symptomatic, I would leave them alone. Supraventricular ectopy can be the same. It can be extra beats. They're called PACs, premature atrial contractions. Again, we generally don't treat them if they become incapacitating at all. We usually go with a beta blocker to see if that helps. How often do patients end up with pericarditis? It's about 5% of patients will get a pericarditis, maybe less, but I quote 5%. Is there any metal in the clip that would cause a problem having a CT scan? No, these clips are titanium. They will not, there's no iron in them, so they will not go off in a metal detector. If you need an MRI in the future, these are MRI compatible, so you can have your MRI. They will not go off when you go through the airport. Is it necessary to take an anticoagulant if rate and rhythm control meds are keeping the patient from having AFib episodes? That's a hard question to answer, but in general, I say if you've had no AFib for 6 months, then the risk of taking the blood thinner may be greater than the benefit of taking it. Because as I mentioned at the very beginning, as surgeons, Seth and I always look at risk versus benefit. You have to as a surgeon. What's the risk of the surgery? What's the benefit? And I think you can do that with AFib too in general. What's the risk of any procedure or medication versus what's the benefit? And I think if you're not having any more AFib, stop the blood thinner. What do you think, Seth? I mean,
I don't know. It's a tricky one. You know, some of my research with AFib is they say that sort of paradoxically the amount of AFib you're having doesn't really correlate with the stroke risk and the clot risk.
That's true. Yeah.
For those
of us scheduled in Min-Jude for a Minimaze, there's a possibility we may still be moved up. Oh yeah, we're adding another day to each week, so the schedule's quite fluid right now. We're trying to move people up. So I tell people if you get a date, just get in the queue, and there's a good chance you'll be moved up. Seth, you got moved up a lot, but you weren't on blood thinners, and you were kind of local.
Yeah, I mean, I got moved up 7 months, I think. Yeah. So, you know, just be prepared if you're on a few weeks' notice to go if you're able to.
Should I have my left atrium measured before the interview? Yes, by an echo. It's a non-invasive test. They rub gel on your chest, and they can see the size of the left atrium. It's not as accurate as a CT scan, and we do a CT scan a day or two before the procedure, but it's a good estimate for us to look at. After a Minimaze, does your CHAD score still determine whether you can stop blood thinners? No. It's based on whether or not the appendage is closed. I don't care what your CHAD VAS score is. If your appendage is closed, you don't need to take a blood thinner, unless you're taking it for another reason. If you're taking it for a blood clot in your leg, that's different, of course. Can the Wolf Minimaze deal with combination of fib and flutter? If the flutter is from a previous ablation, yes. What's the dose for low-dose amio? It's somewhat based on your height and weight, but if your normal body habit's about 100 milligrams a day, if you're a large person, it's 200 milligrams a day. Oh, I'll take this as the last one. No question. Just wanted to wish Dr. Wolf a happy birthday. I like that. You don't have Mr. Producers, you don't have the picture of that. This was yesterday if they have it. I don't know if they were able to. There it is. That's Seth, this is me in my office yesterday. I was surprised by some of the nurses with a bunch of cupcakes, which I certainly don't need, and some happy birthday wishes around the office. So that's me in the office yesterday. Thanks so much for joining us. I think it's been really helpful for people to hear another surgeon's perspective on this. Thank you also for offering the work you've done and on social media and the sites that they can go to for more information. Any closing remarks, and we'll wrap it up.
Well, I'll just wish you a happy birthday too. But thank you. It's been fun.
Yeah, thanks so much. This will be available about as soon as we're finished. Join us again next month, first Tuesday of the month, 5 p.m. Central Time, for DeBakey CV Live AFib. Dr. Evans, thanks so much.
Thank you.
So long, everybody.